Sheila is the director of, as I said, of the UNAIDS Regional Support Team for Eastern and Southern Africa. She provides leadership, and she really does provide leadership, in the regional response to HIV and ensures technical support to the UN country teams in 21 countries across the region. But I think she does much more than provide technical support. She is a very inspiring figure who is a former Member of Parliament and was Minister of Health for in Botswana from 2004 to 2009. And we're very much aware in Ireland of just how challenging it is to be Minister of Health anywhere. And that's a major issue in Ireland. But so we know that you did huge work. She was a Professor of Nursing and Director of the World Health Organization's Collaborating Centre for Nursing and Midwifery Development in Primary Healthcare for Anglophone Africa at the University of Botswana. As Botswana's Minister for Health, she led a forward-thinking and focused HIV prevention, treatment, care and support programme, which is referred to as a model today, and which gives her huge credibility in Africa when she goes to, frankly, tell African leaders what they need to do, because she led in Botswana. As chair of the SADC and African Union Ministers of Health, she provided leadership in the adoption of the SADC Malaria Eradication Programme, the SADC HIV/AIDS Plan of Action, and the Maputo Plan of Action on Sexual and Reproductive Health and Rights. She holds a PhD in Nursing Sciences and postgraduate certificates in Women's Health and Gender Studies from the University of Illinois, and she has authored many publications on gender and HIV and has received many national and international awards. She is the United Nations eminent person for women, girls and HIV/AIDS in Southern Africa, and I know from talking to her earlier that she received recently a lifetime, although I don't know why it's a lifetime achievement award, because there's much more achievement to come, from the King of Thailand, I think. And when she was leaving some palace or temple there, she heard, some Americans were heard saying, "Oh, who is that? It's some VIP, it's some African queen." So we are really proud. We are really proud to have you here today and looking forward to your lecture. Thank you, Sheila.
Okay. Thank you. Let me just start thanking Irish Aid for the Director General and the members of staff who've really been great since I've been here. Nikki and the teammates. So it's good to be here again. I never thought I would be able to come back, so maybe I did make an impression or whatever. But it's great, and I can come back again in another 8 years. It will still be great. But just to say that I'm also awed to be in the presence of Sister Miriam. Sister, thank you so much. It's great to be sharing a stage with you. And I know, I keep saying when I grow up, I'll be you. But I think I'm getting there. Yeah. Okay. So I'm really the thing is keeping HIV on the agenda. As you are all aware, Agenda 2030 is now the Sustainable Development Goals. So that I'll be focusing on the Sustainable Development Goals, but also on where we are. So let me look at. I have a few objectives. Being a professor, I always believe in fitting objectives that I'll have, Father Michael is my personal mentor. And really my response using evidence-based response really came from his own interventions, and hence my leadership journey in the AIDS response. I'll discuss AIDS in the post-2015 era, added value of Ireland in the AIDS response, and indeed, we take heart and really praise the fact that even in the darkest hour, as we say, for me in my region, the impact of Irish Aid was felt. As I went to Karamoja in Uganda, and being with the Irish ambassador and really knowing that part and parcel of this was really to get our people to respond to as timelessly to HIV as possible. I felt really proud of the fact that Ireland was still there, whereas some other countries did sort of pull out to say we are in a recession or whatever. But so I think let's give ourselves a hand for give them a hand for having done that. It's really yes. But I'm able to show what else we're doing in the region, because I want that leadership, in partnership to continue. But lastly, I'm hoping that we do have young people here. I'm hoping that what I'm saying will be able to inspire them to really say, how do I then participate in the implementation of the Sustainable Development Goals? As far as I'm concerned, all 17 of them are related to HIV and AIDS. And indeed, anyone that you focus on will be able to have an impact on HIV, especially in the developing world. So Africa, there we are, our great Africa, and I want to recognize my ambassadors here. It started from being a hopeless continent, one battling with AIDS, to Africa rising. And indeed, recently, about 4 years ago, we actually had the same economist saying, the end of AIDS. Yeah, so it shows that with partnerships, we can be able to do something. And okay, here is the famous, is this about sex? Yeah, but he's always been my mentor. And the way it started has really been when he first surveyed tertiary education institutions and the response to HIV in Africa. And his thing was really that there is a thick cloak of ignorance, lined with layers of secrecy, denial, fear, stigmatization, and discrimination. And the fact that even the approaches that were being done were sort of piecemeal and really not getting to the brand. So he was really advocating, based on evidence, that we need something that is comprehensive, but that tertiary level institutions are really in a unique position to be able to do research and to shape policy and the response to HIV and AIDS. I don't think a lot of them people were listening to him, especially the policymakers. But then, people like us who were, in the institutions were able to listen. So at the University of Botswana, I became HIV and AIDS coordinator in 2001. And I actually started having a policy that included testing, curriculum integration, research, prevention, treatment, care, and support services for students and staff, including provision of antiretroviral therapy, because at that time, Botswana had just started providing that, and prevention of mother-to-child transmission. But because already at that time I was also a gender person, I made sure that we had a policy on sexual harassment and really trying to make sure that women have the right to exercise control over their sexuality without being, pressurized. So that's where we are. We used to meet, and being a Catholic, you'd say to me, are you giving them condoms? And I say, Father, the condoms are not for Catholics, they're for the other ones. Because he really wanted to know, you a Catholic? I said, no, I practice evidence-based Catholicism, but let's leave it at that. I will move ahead. So anyway, but I mean, that kind of, working on evidence really did influence my own role as an academic, a scholar, a consultant, and, a gender activist, in that I was able to generate knowledge and know that the community does matter. So I was able to found the Society for Women and AIDS in Africa in 1988 with other activists, and because we knew really women, the impact of HIV on women was that enormous. So one of the things that I managed to benefit from was that I trained nurses, mostly nurses, and a few medical students, as gender and HIV scholars, where they were doing research and all that. But then when I became a minister, I needed each and every ministry to have an AIDS coordinator. And guess who the coordinators then became? My very students. So my work as a minister was really great, because I was able to then make sure that whether it was Ministry of, the Ministry of, let's say, Agriculture or Education, there was a coordinator who was responsible and could also liaise with other ministries in the AIDS program. And that became a real success. So as a politician, I was able to work with communities, carers, and he's already talked about the program. But Botswana was the first to give free prevention to mother-to-child transmission services in all health facilities with 100% access. We saw the rate of mother-to-child transmission go down from 30% to actually by 2004, when I came out, it was 8%. So within 4 years, we had been able to do that. But it was simply because the primary healthcare aspect was already there. And of course, we had political will and commitment. If you look at the budget was 22%. When the President Mukhai said to me, I want you to come from the university, take sabbatical leave, I need you to come and be a minister. I figured, well, we are in a honeymoon here. So I said, I want 15% of the budget. And he said, I'm giving you 22, but I need a report every 3 months because we got to end this thing. And I nearly died doing it, but I had support, my fellow students, I had support from civil society. And indeed, with that kind of money, and also later we were joined by PEPFAR, we were able to work therefore with the Ministry of Education to ensure that we had life skills curriculum in the ministry. Now, this is a country where already 97% of the children were in school. So they became a ready target right there where you're able to say, okay, let's see how then we integrate HIV/AIDS issues into the whole curriculum. And it worked very well. So MDG 6 did say that we must halt and begin to reverse by 2015 the spread of HIV and AIDS. And I'm trying to show you that, yeah, we have sort of delivered it, but there is no room for complacency. Throughout the world, since the start of the epidemic, 76 million people became infected. And right now, there are 36.9 million people living with HIV. And a little over half are women. So it is still a women's epidemic. But if you look at 76 and 36.9, the other 30-something million people have actually passed on. So that a lot has happened. We've lost lives in this epidemic, and that's why we really feel we cannot lose anymore. But we are seeing that we still have rising new infections, and most of them are among girls aged 15 to 24. And this is where, of course, Irish Aid comes in. So Eastern and Southern Africa, it is 22 countries, from Eritrea to South Africa, including the Indian Ocean islands. So it's the region that's most burdened by the epidemic, and indeed, it is the region that yours truly is responsible for. So among the regional directors, there are 3 regional directors: Western and Central Africa, Eastern and Southern Africa, myself, and then Middle East and North Africa. It's like I have to show the results even more than the others. Of course, it brings about also that kind of complacency. But that's Eastern and Central Africa, and really the prevalence of the epidemic. But of course, now prevalence, I'm sure later we will be seeing more green, in the sense that as people become alive, and we want people to be alive, but we also want there to be fewer new infections. But those are the new infections that we had. And AIDS-related deaths, 460,000. You see how they've come down. But the great part is that we do have coverage of mother-to-child transmission at 88%. This is universal coverage, and you'll be able to see what then has happened. In terms of coverage with ART, it's just a little over 50%, so that we are seeing a decrease in the number of deaths. So 15 countries make 75% of the global burden of HIV, and 9 of them are in my region, Eastern and Southern Africa. So the first 3, as you can see, South Africa, in my region. We have Nigeria contributing 9%. You see, Nigeria, because of its population, even when you say 1%, you mean a lot of people. So that it's really one country where there is complacency in worker, because they think, well, our prevalence is, they'll say, well, we are not like Swaziland, but in Swaziland, Lesotho, those are fewer people. Much as we'll say the prevalence is that high, it's fewer people. So for some of these countries, because of their population, they bring in more people. Look at India, 6%. So anyway, the main thing for me here is that we have those countries that are contributing the global burden of HIV. 9 of them are in Eastern and Southern Africa, and these 9, 8 of them actually are the ones where Irish Aid is actually very much interacting in. So I think it is something that we should be grateful for, and really say, okay, we need to therefore work in such a way that you can be able to show results. There are the Ugandas and all that. So, but we have results of those partnerships with Irish Aid. What are the results? Look at the decline in AIDS-related deaths between 2005 and 14. So the idea had been, we want what? 0 new infections, 0 discrimination, 0 AIDS-related deaths. These are the AIDS-related deaths. Okay, we are getting there. This was supposedly by 2015. Now we're saying, well, we get it 2030. But if you look at those graphs, I think we, with concerted efforts and making sure that we stop new infections, we will get to where we have really, we can end AIDS as a public health threat. New infections among children, the success of the programs on mother-to-child transmission, we've had a 70% decline in that. So this is like a low-hanging fruit, and we keep saying to people, we can be able to do this one. Let's, work, especially with civil society and the women themselves, and we can be able to end this, this epidemic. But where we are failing are the new infections. It's not easy. This is a behavioral issue, but we've had only a 30% decline. Look at our targets. For 2015, the first red dot, and the next one, the target for 2020. Unless we do a miracle, the dots are just someplace else, and those lines are going someplace else. You can see her. Poor you. So anyway, so basically the world has delivered on MGG6, but gaps remain. 17.1 million people do not know that they are living with HIV. So most of the time when we say fast track and we say 90, the first 90 is saying we need to get more people to know their HIV status. Because when they know, then they can either be able to prevent, if they are HIV negative, they will then be able to prevent HIV for themselves. But if they are positive, they can access treatment, especially now. With WHO, the treatment guidelines are saying test and offer treatment right away, because treatment is also prevention. So we're hoping that we can be able to go on. But the main thing is that we also need to get the children. Adults are on treatment, much as 22 million are still not accessing treatment because they don't know their status. However, children, about 1.8 million, this is throughout the world, are still not accessing treatment. So we have encouraging news in that much as Eastern and Southern Africa is the most burdened, of the 15 million people on treatment throughout the world, and by the way, that's one target that we reached in March this year. The idea had been 15 by 15, that we will reach 15 million people on ARVs by December 2015. We reached that target in March, which to us was really great because a lot of people are saying they are crazy. They can't have such a target. They'll never meet it. We met it. However, I'm glad to say that 11 million of those people, the 15 million, are in Eastern and Southern Africa. So it's a region of highest burden, but also a region where we are seeing also the response. And indeed, South Africa alone has 3.2 million people on treatment. But that's only a little over 50% because it's 6 million people who are infected in there. So we need to get them. Gender inequality is a challenge. Stigma, adolescent girls and young women are definitely left behind. There is poor access to educational opportunities, especially the very issues that Professor Michael Kelly has been dealing with. They are financially dependent. And if you are financially dependent on somebody, you cannot negotiate safer sex, let alone refuse unsafe sex. So, but the main issue, of course, is really gender-based violence. And there are many forms, just the common types of violence that are throughout the world, not just in Africa alone. Sexual abuse of children, forced, they keep saying, I don't like this word of marriage. I usually say it in the inverted commas, because it is no marriage. I don't know why we call it that. To me, it's forced child sexual abuse or exploitation, because this is no marriage. But, we call it that, and of course now it's almost like glorifying it. Yet it should not be something, to marrying an 8-year-old should not be something that is glorified. but, it's there and we're working hard on it. And I think Irish Aid, is also one of our partners in that, looking at what are some of the issues. So violence comes in all forms, intimate partner violence, and, as well as trafficking of women and girls. That is occurs throughout. So there's a girl child. What do we want to do for her? In Eastern and Southern Africa, we are finding that with Irish Aid and development partners, we have actually programs that we know are working for women, for adolescents, providing information and services, especially comprehensive sexuality education and services. We were able to get our ministers of health and education, 21 ministers of health and 21 ministers of education got together and were able to say, how do they collaborate at country level to ensure that children have, education and services? It has always been something that's controversial outside, but for us in Southern Africa, we're able to sit down and say, what is the kind of curriculum we want and all that, and we're implementing it. And it's going on very well in countries like Zambia, Malawi, where also the elimination of child marriage is on, and we're working with traditional healers, so traditional leaders. So we're trying to really look at eliminating gender-based violence and harmful practices as part and parcel of the comprehensive sexuality education. But most important, the support, the social support, and especially for orphans and other vulnerable girls. For example, cash transfers, the social protection aspect. That's one thing that Irish Aid has been able to help with, and it is working wonders. It is really interesting how even parents, just for that little amount of money, will ensure that that girl stays in school, will refuse any attempts to marry her, and ensure that she reaches, at least past secondary education, because they are finding that every year spent in school actually does help that much to reduce the chances of the girl child being infected. So the sustainable development goals have been adopted, they're there, and as I said, they're all relevant to the AIDS response. A lot of people say only number 3, good, the thing on good health, but look at where they are. For us, we are targeting 0. SDG number 3, number 5, gender equality and reducing inequality in general, promoting societies and means of implementation are all issues that have to do with us reaching our 90-90-90, resulting in 0 new infections, 0 discrimination, and 0 AIDS-related deaths. I've already talked about this 90, but let me simply say that for us in Eastern and Southern Africa, the priority is therefore looking at the 90-90-90, especially looking at the gender issues, has been on testing, innovative testing, whether it's provider initiative, community, door-to-door. Some of it's actually being tested. For example, Lesotho is trying to look at door-to-door HIV testing and see what's happening, and really using, but also the treatment cascade, eliminating mother-to-child transmission, but also reinvigorating HIV prevention, because in the ultimate, we cannot treat ourselves out of the epidemic. We need prevention and prevention and prevention. So whether it's biomedical or behavioral, we're trying to really push that, including voluntary medical male circumcision. Just recently at the International Conference on AIDS and HCDs in Africa, we were celebrating 10 million male circumcisions so far. And, but I had to tell them that we need another 10 million, by end of next year for it to make an impact. So we are hoping that we'll entice men in whatever way to come forth and test. My husband used to have a thing on his clan. It's quite a lot of men. He called it Operation Snip for the Queen. If you went and had a circumcision, as you were healing, you came and you had dinner with me, just the 2 of us. And it was great. I mean, we got more than 50 guys circumcised within 2 years. Why? Because everybody was like, you had dinner with Sheila? Oh no, I'm going to circumcise. I mean, if it was just for that. And it worked. So those are innovations that we're hoping that we can really do to get a lot more people, to test. So let me look, this is the last slide. What is then our role in ending AIDS? and means of implementation, and really the Irish aid, Ireland's added value, is ready to continue the great work, working with the Global Fund, with the countries, with civil society, with UNAIDS, but really insisting also on seeing results, because in the ultimate, we need to be able to say what is working, what is the best practice that can be replicated in another place. Advocacy, ensuring that no one is left behind. Key populations, we young women and girls, we need that, and we need also legal reforms, because right now, sometimes you go into a country where they say to you, we cannot test young girls because age of consent is like 18, and she's only 12. But if the 12-year-old is looking for, an HIV test, and he's saying, I am actually sexually active, what do? Do we then just throw them out or whatever? So those are some of the issues that we still need to be able to work with countries on, and we are working with some of them. They have actually been able to change their things. Strengthening community systems, but also monitoring the implementation of especially the global commitments. We have quite a few global commitments that a lot of our leaders go sign and then forget about it. Where still, they are signed by ministers of foreign affairs, but to be implemented by ministers of health. Half the time, they don't even know what was signed. So we need that. I mean, I'm finding where I go to countries, and I have to say to a minister of health, do you know anything about the platform for action, the Beijing? And he's like, yeah, well, I heard about it. It's supposed to be implemented. So that collaboration at country level is very important. But most important, and that's my last thing, is that we need political office by women, because I'm seeing that women do ensure good governance, commitment to human rights, and I mean, I'm seeing myself, but also the ladies that I was working with. And for a lot of young women, I'm hoping young women are listening, I usually say to them, let's remember the very first man on earth. After they had eaten that forbidden fruit, and God said, what did you do? A nice guy could have said, well, we were tempted, we didn't know. No, this guy said, the woman that you gave me made me do it. Men never talked for us then, they never will. So we need to be able to talk for ourselves, and that's really good. So with that, let's simply just forge ahead and ensure that we make, the end of AIDS by 2030. Thank you very much.